Guys, after subscribing to this channel, please make sure that you also press the bell icon so that no notification, no new video of mine, any educational video, is missed by anybody.
What do you do with the high-risk patients, and how do you identify the high-risk patients from the crowd? High-risk patients are the ones who have one of these obstetrical histories. Previous fetal growth restriction, not SGA, fetal growth restriction. Previous SGA with stillbirth. So remember I was telling you moderate risk, it looks, so uncanny that we are talking about previous stillbirth and we're putting it in a moderate risk category. She should have been a high risk category, right? But she becomes a high risk category when we know that the stillbirth was because of SGA. Suddenly she becomes high risk, right? Or a previous history of hypertension. These patients are very high risk for fetal growth restriction. Or she has a current medical condition of a chronic kidney disease, hypertension, SLE, Apla syndrome, cardiac disorder. Such patients are very high risk for a fetal growth restriction. And similarly, I'm talking about the other parameters which are very difficult to remember always. PAPA less than 5th centile, inhibin and AFP more than 2 medians of mom, echogenic bowel, or single umbilical artery. All these are high risk factors. Of course, the current ones are difficult to remember because they're mostly ultrasound and biochemical based. So it's PAPA, inhibin, and AFP. PAPA, inhibin, and AFP, and echogenic bowel along with single umbilical artery. All right. In these patients, when you do find out that they are high risk, what do? You offer, you don't consider. Here we were considering the low-dose aspirin. Here you are offering the low-dose aspirin. That's all you need to remember. Don't go about all this, okay? Just remember that you are offering LDA. And not just this, what else are you doing? You are following her up with the uterine artery Doppler. You got her to be a fetal growth restricted patient. I mean, she's high risk, I'm sorry. She's high risk for fetal growth restriction. So you will ask at the anomaly scan, please do the uterine artery Doppler. Or if you want, you can even get it done before that, 16 weeks, 18 weeks, get a uterine artery Doppler done. And as per the uterine artery Doppler and the estimated fetal weight at that particular point, you will decide the further course of action. Are you with me, guys? Or am I going too fast? Please let me know. Am I clear up till now? All right. Pragati, thank you so much for your response, and everybody else who feels that I'm going faster, who are not able to catch, who have any doubts, you can ask me anytime during the class. I'll be more than happy to answer you because it's a very important concept. Once you know this, all other guidelines, be it FOXY guideline, be it ICOG guidelines, be it any other guideline is actually made from these guidelines. And all the small tidbits that you keep finding in your AOGD bulletins and everything everywhere else, it's actually an amalgamation of this guideline, trying to make it easy, but actually nobody is absolutely able to make it easy. But this time, tonight, you will find it easier. I have my few charts that I have enclosed. 1, 2, 3, 4 charts. If you do these 4 charts, everything will be easy. And a little bit, 1 or 2 charts, 1 or 2 slides that I showed you in the beginning that gives you an idea what SGA and what FGR is. What is the difference between SGA and FGR? If you do those maybe 7, 8 slides, you're done with this topic. And you won't have to cram it. It's very, 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 very logical and mathematical, guys. Now coming down to what I was trying to tell you. So once you caught the patient at booking, you caught her that she has a high risk of developing fetal growth restriction, and you mark it there. Then what happens is that the next time she comes for a scan, or you call her up at 16 weeks, 18 weeks, you ask her to go for a uterine artery Doppler. The moment she goes for a uterine artery Doppler, obviously her estimated fetal weight will also be done at that time, the same scan. And you see 2 things. You see how is the uterine artery Doppler doing, and you see how is the estimated fetal weight at that point. So if both are normal, no problem. 32 weeks onwards, you will do this. Do the serial ultrasound scans because she's a high risk patient. You can't just leave her on fundal height, right? So you're calling up for serial ultrasound scans from 32 weeks. You're taking that much risk. You're calling her from 32 weeks, but you're calling her every 2 to 4 weekly. Not 4 weekly, 2 to 4 weekly. From 32 weeks onwards for serial ultrasound scans for estimated fetal weight, and if that goes deranged, then umbilical artery Doppler. Okay. Once the fetal growth restriction or estimated fetal weight goes below 10 centile, you are on high alert. The next step is, come on guys, let me hear it out from you. Everybody who's there in the class, come on. Once the estimated fetal weight dips below 10 centile, then what do you do? Anita, I have very high hopes with you. Anita, Meghna, you are all my old students. You know, Pragati, again, Shrishti, very good. Kajal, all of you are my old and very, very interactive students. So I need an answer from you. What do you do? The moment it dips, which Doppler? Very important to specify which Doppler will you do. If the moment of estimated fetal weight, yes. The moment fetal weight or the estimated fetal weight or the abdominal circumference dips below 10 centile, the next step is to do umbilical artery Dopplers. Okay, but before that, right now I'm sitting where I'm sitting. I just got, I saw this patient and I felt that no, she is going to be a high risk for fetal growth restriction. I marked it in her file and I called her for a uterine artery Doppler. And the moment I called her for a uterine artery Doppler, see, you were seeing her at around 12 to 14 weeks. The earliest you can call her in maybe what 2 to 3 weeks again for a uterine artery Doppler. And now you saw that the uterine artery Doppler is fine, but estimated fetal weight is going less than 10 centile. Up till now, uterine artery Doppler is fine, but the estimated fetal weight is now going 10 centile. So now you're at a high alert. Now you started doing serial ultrasound assessments from 26 to 28 weeks onwards till delivery. And these serial ultrasounds will also have umbilical artery Doppler because estimated fetal weight has gone below 10 centile. So there is no question. Very good, Anita. Very good. Yes, you do the umbilical artery Dopplers first. If they go deranged, then you have your hopes on ductus venosus. And nowadays, one more thing has been added. Come on. When we've already reached there, let's hear it out. One more thing has been added now, which I spoke in one of my classes before. Once the umbilical artery Doppler goes deranged, absent or reverse, you are dependent on ductus venosus, agreed. One more thing you're dependent on. What is that? It's going to come in the charts. Let me see the gold medalist of my class. Who gives me this answer? I repeat my question. The moment estimated fetal weight goes below 10 centile, you are dependent on umbilical artery Doppler. If the umbilical artery Doppler goes absent or reverse, you start depending upon ductus venosus and one more thing you do. Okay, I'll not give you the answer. I'll just wait for the answers. Let's see. Somebody is going to give me that answer, and that will be the gold medalist of my class. Nice. I'm giving you some time. This is as per the latest guidelines, green top guidelines by the RCOG. NC is not the answer. No. This is all Indian guidelines, okay? The RCOG, and very soon we are going to start following those guidelines, very soon. So it's always good that you can, imbibe the guidelines faster. Not uterine artery anymore, guys. Okay? No gold medalist then, right? No. When we'll get to it, I'll tell you. There is something which is now called ductus venosus. I said already. Ductus venosus, and one more thing you depend upon. Some smart people are going to go and look at the GTG right now, huh? Reversal, absent A wave is sufficient. Already doomed, baby. Yeah, absent ductus venosus is sufficient. No, that's not the answer. The answer is computerized CTG, which is now the most important thing to be dependent upon, and then there is a short-term variation in the computerized CTG, which is the thing which is highly correlated with bad outcomes. So short-term variation has to be seen in the the latest computerized CTGs, which I have not seen, never worked on that, but nowadays that is there. See, CTGs were the problem before. Most of the medico-legal problems were happening because the CTG was subjective to understanding of the interpreter. The same CTG, for me, it seems ominous. For somebody else, it's suspicious. For somebody else, it is wait and watch. And there were a lot of medical legals that happens. And how many times have you yourself, been in this dilemma that sometimes certain patients, they have thick meconium stain and absolutely fine CTG. So you took a CTG, was fine. You waited for some time, and for some reason you had to go for a cesarean section, and you saw thick meconium stain. And baby also coming out compromised, but the CTG was fine. In the other circumstances, the CTG is bad, pathological, suspicious, and liquor comes out to be clear. Baby comes out crying. So CTG was highly subjective. So nowadays we've got computerized CTG, right? With short-term variation, yes. And this is the thing we are depending upon the moment, umbilical artery Doppler go absent or reverse. One is definitely ductus venosus. Everybody of you remember it very well. I'm very proud of you. It's not an easy thing to remember. And the other very important thing by my class tonight that you will remember will be the computerized CTG and the short-term variation. Okay.